Okay, thank you. Good afternoon, Professor Khanna, Dr. Doni Firman, Dr. Antonia, Dr. Rini. Thank you very much for inviting me to present our case from National Cardiovascular Center of Harapan Kita, entitled "The Acute Embolic Occlusion of the Renal Artery After Bental Procedure." So the subtitle is "The Role of Primary Renal Angioplasty." As the introduction, acute renal occlusion is uncommon emergency problem. The diagnosis is often missed or delayed, not only because of its rarity, but also non-specific of clinical presentations. Sudden and complete termination of arterial blood supply to the kidney may lead to renal infarction and complete loss of renal function. This is the case. Mr. A, 36 years old, coming to our emergency room with the worsening flank pain since one day before. Why he's coming to our hospital? Because he had a history of Bental procedure on 2016, and he's coming back with the worsening flank pain with the fast score 8/10. Also, there is symptoms of nausea and vomiting. But there is no chest pain, dyspnea, palpitations, no history of trauma and fever, and the urination is within normal limit. This is the previous medication of the patients. He got warfarin, 30 milligrams once daily, bisoprolol, and candesartan. Okay, so this is the echocardiography result of the patients show normal systolic LV function with LVF 55%, and the normal mechanical prosthetic aortic valve with the aortic conduit is seen open well, the normal RV and normal other valves. So because of there is symptoms of flank pain, so we perform abdominal ultrasound, but there is no sign of kidney stones and the normal intra-abdominal, no mass in the abdominal. I'm sorry, I cannot show my cursor here. So the
Yes, we can see your cursor.
Okay. Yeah, sorry. The laboratory result show that there is increasing of ureum and creatinine with low EINR levels and high D dimers. So from this examination, so we build the differential diagnosis in this patient. The first one is the renal colic at causa nephrolithiasis. The second one is acute aortic dissection, and the least one is acute renal artery occlusion. Because there is increasing in the dimers, so we also, and this is the patients with the previous Bental history, so we suspect it is aortic acute dissection. But since there is no kidney stones in the abdominal ultrasound, so we exclude the first diagnosis. So we perform the CT angiography. In this CT angiography, we can see there is normal conduit of the aorta, normal size of the aorta from the ascending to the descending. So we can exclude the dissection. But we can see there is in this second part, we can see there is no flow or total occlusion in the left main renal artery. And then also we from the axial, we cannot see the opacification of the left renals because of there is total occlusion of the artery. And then we perform the renal angioplasty. It is also confirmed that there is total occlusion of the main left renal artery. And then we, with the microcatheter, coronary microcatheter, and floppy wire, also coronary wire, we try to cross the lesions. And then after crossing the lesion, we perform predilatation with a coronary balloon 2.75, and then After the predilatation, we can see there is the flow to the artery and the segment of the main renal of the left renal artery. But we can see there is stenosis on the ostial part. So we perform the stenting in this ostial to proximal main renal artery with the stent, coronary stent 4.0. 80 millimeter. And then after the stenting, we can see there is flow to the main renal artery, but there is still the residual thrombus in this part. So we give the APVIC, GP2B3A inhibitor bolus, and then anticoagulant infusion afterward. So the follow-up after the procedure, the flank pain subsided completely, so there is no pain anymore, and the creatinine level returned to the baseline of these patients. It's a little bit higher, but it's returned to his baseline. And then we see from the ultrasound, we can see there is a normal size of the left kidney, and also we see the peak systolic velocity of the main renal artery is still within normal limit, with the resistive index is still normal. So what the guideline says about renal artery disease, there is on 2017, the ASC guidelines tell that the revascularization routinely is not recommended, but it's in the chronic setting. There is no guideline in the acute setting. It's talk about the chronic setting. So what should we do in the acute renal artery occlusion? So the exact role of endovascular therapy remain controversial and uncertain in the literature. The main goal of the endovascular therapy remains to establish blood flow to ischemic kidney, just like coronary. So we want to preserve the remaining renal function. So what is the treatment strategy? The first one from some report is the systemic anticoagulations, surgical embolectomy, but our surgeon didn't have any experience before, catheter direct thrombolysis, and angioplasty or stenting. But there is no many report on this setting. So what is the renal catheter direct thrombolysis? Some report Bloom et al. On they studied 14 patients with acute renal artery occlusion treated with low dose thrombolysis and achieved successful revascularization in most of the patients, but it doesn't restore the renal function after that, and it not indicated after the kidney tolerance, ischemic tolerance more than 90 minutes. And also Pivaretti showed the same thing, that there is in 4 cases there's also good result with the CDT and stent angioplasty. Okay, technically the CDT is not easy to perform. Also in our cath lab, we didn't have any dedicated catheter for renal artery for CDT. And also it makes the movement of the patients, if we place the catheter for as long as 24 to 36 hours, maybe the catheter will disengage and makes the thrombolytic drugs redirection to the systemic circulation. So the role of renal angioplasty and stenting, most reported success of revascularization in acute atherothrombotic cases, and only 1 reported in embolic causes. Most of the report is on the previous or atherosclerotic base, not in like in this case in embolic case. The thrombotic and embolic arterial occlusion will give the different response to the stenting. The embolic occlusion is considered less responsive and more likely to cause distal embolizations. So in our case, we decided to perform the primary angioplasty in order to achieve faster restoration of the flow. And this one. And after 3 months, the patient came to our hospital with the normal, with the good flow to the segment of renal artery, and with the normal peak systolic velocity of the kidney, and also with no symptoms of the flank pain. So as a take-home message, although extremely rare, acute renal occlusion is an important differential diagnosis in every acute flank pain, especially in those with high-risk thromboembolism. Primary angioplasty and stenting can be effective method of revascularization in acute renal occlusion from embolic causes. Thank you.
All right, thank you, Dr. Suci, for the nice and interesting presentation. Okay, since we already behind the schedule, so I think I will take one comment maybe from the panelists, maybe Dr. Antonia or Dr. Rini.
Thank you, Dr. Doni. Dr. Suci, I want first to say hello to Prof. Khanna. Prof. Khanna, how are you?
I say hello to you. Good to see all of you in this session. Welcome to all of you. And maybe next year, in the next year, June, and the things would be better and we would be able to welcome all of you to Delhi.
Thank you, Prof. Khanna. My question to Dr. Suci is how many % there is of distal embolization or hemorrhage after Bental procedure? And is it the Bental or the modified Bental procedure? Thank you.
The patients underwent a Bental procedure on 2016, but the patient is not took his medication regularly, so we can see the INR level is very low. It maybe cause the distal embolizations to the distal part, even though in the echocardiography there is no thrombus intracardiac or there is no atrial fibrillation on the ECG. But we suspect it is because emboli, because of there is also thrombus on the external right external iliac artery from the CT.
Yes. Okay.
Okay,
Thank you.
So, Prof. Khanna, do you have any idea, any other idea, or any other comment?
No, that is a very well presented and a very well done case, and it's like not easy and very intuitive to actually take care of this thrombus and revascularize this renal artery.
Yes.
We haven't seen many of these cases, but it's a good learning for me to actually see this case and also plan for future in case we have problems like this.
Thank you, Prof. Khanna.
Thank you, Professor.
Okay, let's move to our second speaker. So there will be Dr. Novi Kurnianingsih. She's working in the Saiful Anwar Hospital in Malang, East Java. 1 hour flight from Jakarta. So I hope Dr. Novi already ready for the presentation. Dr. Novi, are you already here?
Yes, thank you, Dr. Doni.
Okay, please.